kicking off the webinar Wednesday for PCNA. I am one of the members of the PCNA Steering Committee, and I'm joined today by Rachel Coghlan, who will be presenting on humanitarian crisis in palliative care. I'd like to acknowledge the traditional owners of country throughout Australia that we are all joining from, and recognise their continuing connection to land, waters and culture, and pay my respects to elders past and present. So I am joining today, I'm currently in Melbourne in the Wurundjeri Woi-wurrung country. You might like to pop in the chat where you are joining from also. So for those of you new to the PCNA webinar Wednesdays, these sessions are really about supporting the palliative care nurses and the broader health workforce by providing access to learning and practical insights, and really having conversations together around palliative care education. So a little bit of housekeeping. Like I said, we'd love you to keep your cameras on. I will moderate the chat, so feel free to pop your questions as we go in the chat. I can just see now we've got Justine from WA, fantastic. Shipsy from Darwin. We've got, I don't know if I'm going to say that right. Is it Quizon from Philippines? Amazing. Daisy and Verna from Darwin, Adelaide, Alice Springs, Gold Coast, Melbourne. That's fantastic to see. So I'll continue to moderate the chat. If you've got questions throughout, please pop them in. We hope to have an opportunity, we will have an opportunity at the end for questions and a little bit of conversation. Just make sure anything that you pop in the chat is respectful of both the person presenting, but also everyone who's joining. The session is recorded. You'll have access to that afterwards. And I think that's sort of all the housekeeping. So I'm really delighted today to introduce you all to Rachel Coghlan. I met Rachel, I think it was maybe 4 years ago, presenting at one of the OPCC conferences, and was just so blown away by the extent of palliative care globally that I just knew nothing about. You sort of go to these conferences and you're really focused on your little local patch and what's happening perhaps a little bit beyond that. But Rachel really opened my eyes to a global context of palliative care that I found really interesting. So Rachel is a practitioner, a researcher, an advocate working across palliative care, rehabilitation, humanitarian response and global health. A Fulbright scholar, Rachel's PhD explored palliative care in the Gaza Strip. She is currently supporting palliative care responses in the Ukraine, Syria and Lebanon. So please welcome me in joining Rachel.
Thanks so much, Holly, and hello to you all. And thanks for turning your cameras on. What a lovely way to do a webinar. It's often staring into an abyss of dark blackness. So really, really appreciate you all turning on your cameras. I'm going to share my screen and get straight in. All good? Perfect. Okay. This is an adapted version of a presentation that I gave at the Asia Pacific Hospice Palliative Care Conference in Sarawak last year. So apologies if you were there and you've heard it already. It's a little bit tweaked, a little bit different. So I want to go through just some of my reflections, research experiences, practice experiences in looking at this, what's kind of a novel idea of palliative care in humanitarian settings. Before I get into it, I want to share a story that a humanitarian colleague shared with me very early in my explorations of palliative care in humanitarian crises. I was at her dinner table one night. She was working in Jordan and I was at her place in Jordan, and I asked her, what does palliative care in humanitarian crisis look like to you? And she replied, she's not a health person or a palliative care person. She replied, I haven't thought about palliative care in humanitarian crisis before. But let me tell you this, it's a story that will never leave me. Last year, I travelled to Somalia with an international humanitarian organisation where I witnessed the devastation that decades of prolonged drought, famine, violence and insecurity have wreaked on the health of its communities. I visited a hospital caring for malnourished children, and I was taken to a room where a young girl lay on a bare table. The girl was screaming in pain, crying out for her father. And she had a very visibly swollen and red-hot groin, having endured female genital mutilation just some days before. Her entire body was in tonic spasms. She was suffering from tetanus as a result of the dirty metal implement used to perform the FGM. She was in absolute agony, but there was no pain or symptom relief in sight. Her father stood in distress by her side, lifting her up in an attempt to ease her pain each time she screamed out, "Papa." I learned that the girl was 10 years old, the same age as my daughter at home. I went close to the girl as she screamed, leant over to her, touched her hand, and whispered gently in her ear a soothing but simple shh, shh, shh. The girl immediately stopped her crying and turned her head towards the sound, searching for my face. Her body relaxed, and for some moments she became still and calm, seemingly comforted, if only fleetingly, by my warm touch and my soft voice. We left shortly after, and I later heard that the young girl died the next day. The story challenged me in many ways, and this was the beginning of my entry into the field of palliative care in humanitarian settings. But it was the responses after I told this story that perhaps challenged me even more. So I presented the story to audiences shortly after this dinner table conversation, and I want to share what happened on two separate occasions. Following the first, a very well-respected and very experienced global palliative care clinician appeared really upset and affronted with the notion that the act of comfort in the absence of medical intervention might be considered a type of palliative care. He'd audibly scoffed in the front row of the audience. "What would you do in this scenario?" I asked him later. "I would just get the morphine in," he replied. "I'd smuggle it in if I had to." He was, maybe nobly, challenging the law and access to medicines in his firm conviction of what was needed then to relieve suffering. And of course, the young girl needed antitoxins and she needed pain and symptom relief. But he was also challenging a conception of palliative care outside a biomedical frame. He saw the extraordinary deficits. And then following the second occasion, a well-respected humanitarian practitioner was due to present her own paper after mine. And as she stood up to begin, she shook with tears and instead had to leave the room. Later, she confided to me that her mother with end-stage dementia was living in an aged care facility. And at each visit, she would sit quietly beside her mother, stroking her hand and calming her with a soothing voice. She had been so moved by and felt so connected with the idea that she was helping to provide palliative care to her mother through the simple acts of presence and comfort. And she thanked me for a story which had given her permission to hug, touch, and humanize her mother, and given her permission to grieve. So this heartbreaking story of the Somalian girl and the passionate and very diverse reactions to it sparked a key question for me in my explorations that followed, mostly in armed conflict settings. What does care for those who are seriously ill and dying look like, and how is it defined across settings and cultures, and particularly in humanitarian crises, where resources are finite, where suffering may be extreme, and communities and the way they care doesn't always look the same. So the presentation I want to share today is about where some of my discussions and research grappling these big questions have landed. It reflects an engagement with historical, current and emerging criticisms and ideas and practices in both palliative care and in humanitarian response as separate fields and at their intersection. And it's drawn from qualitative research revealing the stories and lived realities of people experiencing war and political injustices. You'll hear the voices of my work from Gaza, undertaken in 2020 before the current crisis, and from Ukraine, undertaken in 2024 during the current war. I want to thank all of those people in Ukraine and the Palestinian people of Gaza, on whose land and by whose seas these voices come. And I acknowledge that these ideas and research are fundamentally grounded in their traditional knowledge, practices and rituals of caring in illness and dying that have existed long before the advent of modern palliative care and endure today, no matter how horrific the violent situations. I'm indebted to Indigenous people in all places for the reminder that dispossession and destruction of homes, country and waters is no match for their extraordinary endurance, resistance, truth and hope. So I'll just very quickly give you a little definition of what do we mean when we're talking about humanitarian crises or settings and humanitarian response. So humanitarian crises are often marked by high mortality and extreme health-related suffering. Humanitarian response then is concerned with a whole host of helping endeavours in times of emergency or crisis, whether it's armed conflict, climate crises, economic crises, infectious disease outbreaks, and very often within resource-poor settings. There are various definitions of the humanitarian system and sector, some reflecting the very organised and formal nature of mainly Western and Northern United Nations agencies, non-governmental organisations and the Red Cross, Red Crescent movement, and then others who propose more organic and holistic descriptions that includes anyone locally, nationally or internationally who steps up to provide support. There's different historical and cultural traditions of humanitarianism, but really the mainstream and Western and formal humanitarian system owes a lot of credit to a Swiss businessman named Henri Dunant, who in 1859 stumbled across the Battle of Solferino in Italy. And he documented his accounts of a war describing harrowing suffering alongside moments of compassion and tenderness. And he wrote in his accounts, A Memory of Solferino, that compassionate care manifest in accompanying and soothing the dying is the keystone of humanitarian action. His accounts led to the formation of the International Committee of the Red Cross and bring historical relevance to the relief of suffering and caring in dying, no matter how scarce the resources, and written long before the advent of a modern and formal palliative care. His accounts also led to the development of fundamental principles, the key one of which and the main goal of humanitarian response is the principle of humanity, to protect life and health and alleviate suffering wherever it may be found. So there's clearly strong overlaps between the ethos of humanitarian response and those of palliative care. They also share an ethical root in the recognition of our common suffering and illness and dying and our compassionate action in response to that suffering. Palliative care is, in many ways, an ultimate reminder of why we are there in humanitarian response, not only to save lives, but to compassionately care. And yet, palliative care, at least in any formal or structured way, is not yet well prioritised by humanitarian agencies. I'm going to go through three main challenges and assumptions that are most often written about and talked about of why palliative care is not well integrated into humanitarian response. The first thing is that it's perceived to be beyond the convention of humanitarian practice. Humanitarian medical care brings a philosophical fixation on curing, saving and prolonging lives, to be seen to be doing something in the midst of chaos or crisis. Or conversely, a mindset that nothing can be done for a dying person. And we see this playing out in global health metrics and also in the rhetoric and fundraising efforts of humanitarian agencies that play into an emotion of life-saving heroism. Supporting someone to die just simply doesn't appeal to public sentiment. And palliative care organisations and humanitarian organisations very rarely speak to each other. Secondly, palliative care is perceived to be beyond the capacity of humanitarian resources and systems. Services may often be prioritised for or diverted to those people with acute or curative health needs. And the limits of material and human resources are major impediments in settings of finite resources and a severely underfunded humanitarian system. And this quote is from a paper that I wrote with some colleagues in 2020 during COVID, actually, was the impetus for the paper, where we said pain management drugs are inexpensive, yet in a resource-scarce environment where critical priorities are pitched against one another, more money for drugs may still mean less money for housing, food, clean water, and sanitation facilities. Even practitioners and staunch supporters of palliative care, as we in fact are, may find it hard to argue for pain relief versus bread, rice, or water. While there's strong ethical arguments for the inclusion of palliative care in humanitarian settings, how it actually gets implemented is an unresolved tension. It's often seen as an added luxury and a specialist service for healthcare systems that can afford it, rather than recognising that there's always something that can be done, no matter how small. And then the third challenge and assumption is that palliative care is perceived to be beyond the competence of humanitarian actors. Even where healthcare workers express support for incorporating palliative care into their practice, there's major concerns of a lack of policies, guidelines and training and specialist expertise to support them to do so. And we also see instances of detachment and dispassion from healthcare workers operating in extreme crisis, a turning off of emotions, a lack of empathy, and sometimes dehumanising care. One could argue, though, that that's not a competence problem, but needs approaches and support grounded in humanistic caring, supportive environments and opportunities for healthcare to enable healthcare workers themselves to deliver compassionate care to others. But notwithstanding the importance of these challenges of convention, capacity and competence, there's a far bigger and more fundamental challenge that I want to focus on now. And this is a fundamental challenge that needs to be understood if we are to move forward. So whilst we know that there's clear parallels in ethos and goals between humanitarian response and palliative care, there's also now equivalences in the colonial and specialised nature in which both of these systems seek to transfer knowledge, provide assistance, and understand and relieve suffering. The formal humanitarian sector has become criticised for losing the essence of its response, the principle of humanity. It's criticised for being increasingly professionalised, specialised, and bureaucratised, for being colonial and top-down, privileging the flow of power, money, and knowledge from the global north to everyone else, and lacking in genuine understanding of the diversity of contexts, cultures, and communities, and the solutions that local people themselves bring. Humanitarian health response and global health more broadly are criticised for the transfer of Western biomedical approaches, which may not always fit the contexts that they are designed to serve. As the number, duration and complexity of humanitarian crises increases, criticisms abound that the sector is falling short and no longer fit for purpose, that it's at a crossroads. And the result of these things is that formal humanitarian response efforts will never be able to understand how diverse people and communities want to be supported or cared for, and will never be able to reach all of those who need assistance. At the same time, we have a challenge in palliative care. As with formal humanitarian response, palliative care has a long history of simple and humble beginnings to the increasing modernisation and specialisation seen in a growing number of countries today. The process of being sick, dying and grieving has slowly shifted from what was historically a spiritual and relational process within homes and communities to a medically and professionally managed one within healthcare systems and institutions. Philosopher Ivan Illich argued that dying was yet another aspect of human life which had been colonised and taken over by medical busybodies. Notwithstanding the enormous achievements in the growth of the discipline to improve the lives of more and more people experiencing health-related suffering, there's also now murmurs of discontent, of a one-way flow of knowledge and practices from the global north to everyone else, privileging a Western biomedical, specialised and professionalised approach. And there's critiques of a colonial mindset in palliative care. We could argue then that the discipline of palliative care also stands at a crossroads, and that if we continue down this single path, the result of this is that formal palliative care will never be able to understand the diversity of how people and communities wish to be cared for, and will also never reach all those who need assistance. When we put humanitarian response and palliative care together, we see these equivalences playing out. In the common challenges and assumptions, the three challenges that I've described, we see that palliative care in humanitarian response is often introduced through its deficits and dilemmas. The things that don't exist, the things that need to be fixed. And the panacea we see is often a slew of guidelines, training, essential packages of care, and often parachuting in medical and professional so-called experts from the outside to give their view on what works. The premise of modern palliative care has also evolved to create a semblance of order and peaceful calm. That's what we aspire to fit things into neatly defined and increasingly professionalised boxes, like domains of palliative care or tidy routes to pain and symptom control, when clearly humanitarian crises are not ordered, not calm, and not peaceful. These are reductionist approaches that often fail to grasp the full complexity of systems and the full complexity of suffering in extreme crisis. Rachel Coghlan is a Palestinian health academic who wrote in relation to caring in Palestine after decades of occupation, blockade, and protracted conflict. For too long, people's suffering has been understood through the discourses of the biomedical or the economic. We go beyond the biomedical because the problem here with trauma and suffering is not between the ears. Separately, though, there's opportunities, and both disciplines are trying to respond to these reckonings and crossroads. And there's an important correlation between the parallels in progressive thinking and practice. On the humanitarian response side, there's three concepts currently taking up a lot of debate and a lot of airtime in response to system criticisms that I want to focus on now. The first centres around decolonising humanitarian aid and humanitarian health response, combating structural racism and colonial transfers of knowledge and power, including Western biomedical knowledge. And the second centres around localising humanitarian response, which means recognising the relationships between and the role played by local responders and communities who are often the first to respond and the last to leave, remaining in the communities they serve before, during and after a crisis. It cedes power to local actors and away from big international organisations. And the third area centres on rediscovering the ethos, the essence of humanitarian response. And then on the palliative care side, the discipline of public health palliative care is emerging to reimagine or perhaps reclaim palliative care as a public health concern, attending to the ways cultural, political, social and environmental context influence suffering and caring. And we see alternative alliances like compassionate communities responding to this reckoning. And these evolving ideas and practices are also driven by efforts to decolonise palliative care, to value Indigenous knowledge and traditions, and localised community development and participation. Both humanitarian response and palliative care face a critical opportunity, I think, to work together, to reclaim traditional ethos and ethics and caring in crisis as they seek to advance these progressive ideas. So now I want to draw on the voices and lived experiences of people in Palestine and Ukraine to unpack or illustrate some of these ideas. So firstly, on decolonisation. Even when we might try to be culturally sensitive, culturally adaptive, culturally competent, there's an implicit assumption that the usual or the dominant way of palliative care practices are the way. We may make assumptions that there's a right and a wrong way to be cared for, where anything outside this framing is wrong. Othering creeps into our language and our practices. But meanings of and responses to illness, death and dying are clearly not the same in different cultures or for different population groups throughout the world. In Gaza, for example, caring in serious illness and dying is already recognised as an integral part of culture, religion and humanitarian values, even in the absence of formal or structured palliative care, which there isn't. We don't leave them, one healthcare worker said. You deal with a human with Eastern ideology. We don't leave someone suffering alone. This is not humanitarian sense. We can't leave him. And another said, it's not like a protocol that is adopted by the place where I work. It's more like you feel that there is a genuine urge in yourself that you want to help some people who are suffering. What we rely on for palliative care is only personal effort and religious backgrounds. The potential to support is something very personal and very basic. Common language within palliative care and humanitarian response can also be othering. Words like capacity building, for example, also imply that local communities do not somehow have their own expertise or strengths or assets, or hold existing ways of caring that may be wrong or needing fixing. But in the vast majority of places affected by humanitarian crisis, the practice of offering support of any kind, and no matter how basic, existed long before palliative care as a specific term entered the scene, bringing a new and Western vocabulary. It doesn't always translate. A lack of existence of the term or the formal structures does not mean palliative care approaches have not already been happening. And this was from another healthcare worker in Gaza. I'll read the second half in the interest of time. 6 months ago, there were 2 people who came from an international society, and they met with volunteers who were providing social support with patients here, and they started asking them what they were doing. The volunteers explained to them what they were working on, and these people from the international society told them, this is palliative care. They started to give them examples on how we should deal with them, the patients, and the volunteers were answering perfectly their questions, and they, the visitors, were surprised with how much they knew in dealing with these situations. A palliative care approach which tries to counter a unidirectional transfer of caring, language, knowledge and interventions, and recognises the existing and diverse pathways of caring could help to disrupt colonial ways of thinking in humanitarian response. So then on localisation or localising. Both humanitarian response and palliative care have gradually evolved away from practices embedded in family and community to being dominated by professionals and specialists. And both are guilty of paying lip service and relegating to the margins the idea of community and the relationships within them. And yet, examples of homegrown and localised palliative care in humanitarian crises exist throughout history. And a really stark example is in the late 1980s, when at the very same time that modern palliative care was taking hold as a medical specialty in the UK, across Africa, a mass of grassroots community organisations was emerging. The first responders in the HIV epidemic, the pioneers of a home care movement who provided basic, tender care for those with advanced illness or those who were dying. Multitudes of grassroots, community-based organisations have similarly arisen in Gaza and in many other places throughout the world in response to suffering from war, injury, trauma and illness. And this healthcare worker said throughout history, since we began, in a sense, palliative care was part of our mandate, because when you alleviate the pain and suffering of people who are wounded, traumatised. And these efforts are underpinned by relationships, where the caring for the individual is directly linked to caring within a collective community. And this person with serious illness in Ukraine, displaced from their home, said, "What's most valuable to me? Family care." And another in Gaza, we are a community who are helping one another. Family members, they come together, they stay, they help, or even neighbours. This is the society, though they are not naming it palliative care. It is some sort of care. And then there may be assumptions made that very often don't match with what communities value, or what they need, or what they already do, because they're very often not asked or not involved in determining what their care or what models of care might look like. Localisation means keeping local knowledge, experiences and preferences, and the voices and stories of real people at the core of strengthening caring. People in both Ukraine and Gaza reflected on the need to ensure that community members are at the forefront of determining future pathways of palliative care models. This healthcare worker in Ukraine said we should not be silent about it in order to attract people, volunteers and financial contributions, because this is the humanity of our society. And a healthcare worker in Gaza said palliative care should be involved with everyone in the street, reflecting the idea that palliative care is everybody's business and calling for local and community-led solutions, and gave examples of community forums, community co-design processes, and community mobilisation. And then this one, which I love and use all the time, healthcare worker said, if we want to apply a palliative care system here, it shouldn't be copied and pasted from other systems. If we sit with the wider community, people, professionals, we might come up with different solutions, different ideas. Taking all the resources we have and the social norms into consideration, we need a new paradigm called Gaza's palliative care paradigm. Many aspects of caring that I've described already are universal, but this particular one around suffering stemming from living through extreme crisis is very particular, I think, to armed conflict settings. And I've seen it in Ukraine, in Gaza, and now in current research in Syria. In armed conflict settings, there's a direct relationship between the suffering from individual disease and the social and the collective suffering of living through a devastating war. They're entangled, impossible to tease apart, and sometimes individual illness-related suffering may be even inferior to the pain and the hopelessness and the injustices experienced in war. This caregiver in Ukraine brought those things together in this entangled notion. What emotions can there be because of the war or because of the disease? Of course, nothing good. Constant worries, constantly. Oh, it hurts. Oh, when will it stop? Oh, why does it hurt all the time? When will that war end? These are things that do not leave you for a minute, not for a second, not for an hour, not for a day, because we live in all that and there is nothing good in it. And that pain and that war and those experiences and worries, all of this is very difficult. And similarly in Gaza, this woman with diabetes was sitting in her wheelchair and the door was knocking. Doctor, doctor, come, come. What happened? What happened? She was gasping from her diabetes, gasping from her poverty, gasping from low economic status, gasping just because she is Palestinian and she can't reach and cross the borders to reach improved care. And she died. Measures to alleviate this collective and this social suffering can't be solved by medications and individual therapies alone. They instead require public health, social and political solutions that very likely sit outside our usual or traditional clinical toolbox. And a failure to properly understand affected people and communities, their meanings of suffering and their solutions for well-being could mean more chaotic and distressing environments that could actually cause harm. And then ultimately efforts towards decolonising palliative care and humanitarian response and localising palliative care and humanitarian response, I think are underpinned by a desire to reclaim the ethos and the philosophies of why we're there, as grounded in bestowing compassion, restoring dignity, and providing human connection and solidarity in times of suffering. We need to understand how comfort is best found in crisis. The ways in which care is practiced through acts of compassion, no matter how small, matter enormously in contexts of severe chaos and resource scarcity. It could mean something as simple as an exchange of feeling when the chaos and the trauma is so extreme. This healthcare worker said, I think his name was Sammy, 21 years old. He was complaining of a gunshot directed to his airway. Sammy had a lot of blood coming from his airway. When you look at their eyes, you see something strange. I think also in emergencies, we make palliative care, you know. We are caring for a patient's feelings just to exchange a feeling with the injured, even when nothing else can be done. Or it could mean accompanying, sitting in silence and bearing witness in the midst of profound and collective grief. Someone has become lonely here, or someone's children died there. Here you can only hug and just be silent. Here you don't need to say words. Words like time heals don't work at all. You just listen quietly. And in the context of war and uncertainty for the future, it may mean tailoring care to what will bring the most comfort just in that moment. And I love this quote from this person with illness in Ukraine. She said, I love listening to music. What am I left to do? I still listen to the radio and sing a little. And this summer, as I live, I can sit at least a little outside. Yes, maybe I'll sit on that swing. It's within contexts of severe crisis, adversity, and resource scarcity that these seemingly small aspects of care might become most evident and most important of all. So there's a growing, although it's still early days, I think, in the field of palliative care and humanitarian response, there is a growing field of practice and research that does demonstrate pragmatic, locally led and decolonial innovations and approaches that support compassion, dignity and the alleviation of suffering. Examples span community-based volunteers providing home-based care, task sharing to support non-specialist clinicians to manage symptoms and pain, outreach projects in refugee camp settings, culturally adapted and communal bereavement support, and models that intentionally link humanitarian actors with local health services to break down silos and support collaboration. These 10 guiding principles come from a forthcoming book chapter, which you can't quote yet, even though this is being recorded because it's not published. Perhaps this is for the next presentation, but my colleagues and I, in this chapter, provide some concrete examples of innovation across different settings, different humanitarian settings, and then lay out 10 guiding principles based on such examples of practice. And they're based on many of the things I've talked about today, but really grounded in 3 consistent truths. First, that palliative needs are ubiquitous in crises, and that palliative care must be understood and planned for as a part of humanitarian action. There's low cost and pragmatic interventions, and they need to be grounded in humanity and dignity. Second, that much of the care for these needs during crisis is recognising that it's delivered by first responders, family and community carers, generalist clinicians and local organisations rather than specialists. These groups of people must be recognised, empowered and supported to shape planning and response and to themselves provide compassionate care. And then third, the ways in which suffering is perceived and alleviated are shaped so deeply by social, political and cultural context. And these realities must be embedded in programs that respect and harness contextually relevant approaches to care. So watch this space for that chapter. So to sum up, what's our role in all of this? In the two fields of humanitarian response and palliative care, we've talked about that there are parallels in ethos, there are parallels in critique, and there are parallels in the quest to do better by people and communities. At the intersection of the two fields, we have a critical opportunity to reclaim that ethos and reimagine the future. A future in which we learn from people's individual and collective lived realities in all of its messiness and its chaos and its heartbreak, rather than trying to fit that lived reality into pre-existing procedures, domains, professions, and specialisation. Of course, there's a lot that we can offer to those experiencing devastating crisis and to the humanitarian health field, but there's also much that we can learn from communities affected by crisis. As Rita Jackman says, we need to think and go beyond the ears. Our job is not to start by trying to replace all of the trees. Instead, we need to begin with understanding the profound shoots that already grow, springing up from the dust of the war-stricken rubble, from the drought-cracked earth after the flooding rains, within the poorest communities, wherever there is extreme suffering, to sprinkle a little water and nurture those most universal and human things. And there's a few references I've drawn on for this presentation, which I think you're going to be shared the slides, so I'll leave
Yes, yeah, we will. Thank you, Rachel. Look, I mean, please, to people online, please pop any questions in the chat that you might have for Rachel. I confess I'm overwhelmed, and in the sense that there's so much there that I can relate to, that you can connect to, and then there's just so much there that feels so far removed from what we're doing here currently and the luxury of what the resources that we have and the teams that we work in. From the very first story, I think I still got stuck on that child. It took me a little while to sort of move past that. And yeah, for me, just thinking about choosing between pain relief and housing, or, symptom management versus food, is a really difficult thing to actually grasp when we are living here in our very privileged situation and really well resourced. But there was almost, some of what was coming through too was really beautiful about that connection back into community. I wonder whether people in online now that are working in really remote communities in Australia can sort of relate to some of that experience of not wanting to come in and actually dominate with our current practices, but begin by learning from, as you said, that beautiful, the shoots that are already growing. I'm just checking the chat as we go. Just lots of thanks, that it was fascinating, and it was. I might lead with a question, and that's something that came to my mind, is that we have such clear roles here. We're so defined by scopes of practice and our position descriptions. We're in multidisciplinary teams. We all have kind of set roles. How does it sort of work, I guess, when teams come together, whether that's local teams or international teams? And how does that work in terms of everyone just getting in to get the work done?
Yep, great question. Thank you, Holly, and thanks for everybody's thanks in the chat. I'll approach it from a local health worker perspective, because I think that springs to mind first and foremost. There was a healthcare worker, a doctor in Gaza, who's now a friend. Many of them have become friends through the current situation. And he said to me that even though there are delineated roles and responsibilities, and they do have professionalisation and specialisation in Gaza across multidisciplinary, across disciplines, that there is always a place for him stepping up to go and provide a scooter for somebody if that needs to happen, because the other professionals are simply not around or haven't been referred or are not available because of workforce shortages. And in specific story with this doctor. He introduced me to another participant, a young man who had had severe gunshot wounds to both of his legs. And this young man was having suicidal tendencies, and incredible ongoing pain and suffering. So for all intents and purposes, they would describe him as having palliative needs, even though he wasn't dying, not imminently dying. And he brought this man, well, we went and actually picked this man up so that he could participate in an interview for the research. And along the way, we went to Gaza's best baklava shop, and we bought up a whole lot of kanafe and baklava and made that part of the interview. And this was the doctor who paid for it. And in this interview, this man confessed that he was having suicidal tendencies, and he was really struggling. And the doctor who was there immediately said, "I'm just telling him in Arabic that we really love him." So there was, so the idea of who's providing spiritual support, who's providing social support, all of those things, he was doing it all, and it was the most beautiful example of that.
Yeah. And I imagine it does just have to blend and just become more human, really.
Absolutely.
Yeah. We've got just Peter Gaffney, who's working up in Alice at the moment, working in First Nations communities for a very short period in Central Australia, and so much of what you've shared resonates with his experience up there. Yeah. Thank you, Peter.
Thanks, Peter.
There were some questions that came through with registration as well, which I'll get to. I had another one. I guess here I'm automatically thinking about, the well-being and vicarious trauma of our team and making sure you've got that culture. So I kind of guess I wondered what that looks like. But actually I'm wondering for you in your position and people who are doing that humanitarian overlap with palliative care, how do you not get lost in the overwhelm of feeling like the magnitude of it, of where do I start and how do I help within all of that? Because I'm not sure about people in the audience, but that's something I come away with sort of going, there's just so much in that. It's so big and so powerful. What's the first step and how do you overcome that in the work that you do?
Yeah. I think I think for me, the first step is going back as I kind of tried to articulate, going back to that ethos, and going back to those small but potent acts of compassionate care that that we do anyway, that exist all the time anywhere, but I think are the foundational starting point here. I think it's very easy to get lost in the overwhelm of resource scarcity, to get lost in the fact that the pain relief may not exist in this setting, or that the legislation or the policies don't exist, or the stigmas there around it, and to only focus on that without bringing yourself back, and being overwhelmed by that without bringing yourself back to go, well, what actually can I do? I remember giving a presentation at the PCNA conference in 2020 online when we were in the midst of COVID lockdowns. Everyone was having a terrible time. Palliative care was having a terrible time. We didn't know what to do with ourselves. We were so overwhelmed in our own settings. And my presentation at that time was around the things that we could learn from healthcare workers in crisis settings to bring into our own communities, to know how to respond in COVID times. And that was, a lot of that was around going back to basics, learning to cope with resource scarcity, learning to be okay with not being able to fix everything, or to be able to do everything that you were trained to do. It doesn't mean we shouldn't try, but I think it's getting perspective, and also working out what is most important and what matters most to those people in that context.
Yeah,
which is not always the things not always the things that we might think it is first.
Yeah, and not always being able to do what you're trained to do.
Yeah.
Is there really? Yeah.
Yeah.
We had quite a few questions around what are the sort of essential medications that are available during crises, but I suspect that might vary dependent on where you are. But generally speaking, what are the sort of basic resources that teams have?
Yeah,
In,
completely context dependent.
yeah,
And so context dependent that you may have morphine available, for example, not necessarily currently in Gaza, but previously when I did this research, morphine was available, but it was reserved for the surgery unit, downstairs, and not for a person dying of cancer. Absolutely no way would so huge variation, and huge variation in laws and
yeah,
policies, and
yeah,
doctors' comfort in prescribing these things, and community stigma. Yeah, a lot of that comes from concerns about addiction, that kind of thing.
yeah,
And that's certainly present in both Ukraine and Gaza in this work.
yeah.
Yeah.
Thank you. I might kind of finish up with two things. A lot of the questions that came through registration, I guess, around, what can we do? If you're interested in this particular field of work, are there pathways or organisations that palliative care nurses can connect with if you're interested in learning more about and perhaps contributing in this space and learning from people in this space? And then if you can finish with perhaps a triumph, something, obviously there's a lot of weight and a lot of sadness in some of the work that you do, but perhaps finishing with, the success and the triumphs that you see as well.
Yeah, lovely. Um, so as I said, it's a still a fairly nascent field, but an emerging one. Um, you're not easily going to find job descriptions or job adverts for palliative care practitioners in humanitarian settings. As I said, also palliative care organisations, if they exist in places, often don't work very well with formal humanitarian agencies. So I think there's a lot that needs to be done in terms of breaking down those silos and partnerships and collaboration. There's a couple of organisations that are putting a lot of weight behind this currently, like Médecins Sans Frontières and the International Committee of the Red Cross are starting to think very deeply about this. So there are roles coming up, which is great and really exciting. And I'm involved in a project in MSF with MSF in Ukraine at the moment. It requires a little bit of creativity if you're really wanting to get involved. So the first thing I would say is to reach out to regional or local palliative care organisations, and we can be advocating to them to be thinking more about crisis contexts. And there's a lot of parallels between low resource settings and some types of humanitarian settings as well. But a little bit of creativity, I think, around where palliative care isn't seen as a priority, where it's not getting the funding support, where it doesn't have donor funding support, tapping into issues that are priority, that do get exposure
Yeah.
and do get funded, whether that's emergency care, whether it's cancer care, renal care, rehabilitation, mental health support. Mental health support often doesn't, it's high priority in humanitarian settings at the moment, but they often don't talk about grief and bereavement. So we can
Right.
be thinking about, okay, how do we tap into these existing priorities so that we can keep pushing for palliative care to be linked in. So I think we
Yeah.
have to be really creative at the moment around that. Yeah.
I think on that actually, we've just had a question from Emily in the chat around out of all the people dying in what you see in the humanitarian crisis, is there any data about what diseases and illness have the highest mortality rate?
I mean, it varies very
Yeah.
hugely across the type of crisis or emergency. Obviously in a setting like Gaza, the highest rates of mortality have been around war-related injuries, but also cancer care. People are no longer getting any kind of treatment. It's just simply not available. So much higher rates of non-communicable diseases coming through now. then you'll have other settings where malnutrition is the number one killer, and we shouldn't need palliative care in these settings because people should just have enough food. But yeah, it becomes an important thing for children dying of malnutrition, for example. So very, very context dependent.
Yeah.
Yeah.
I've got a comment here too from Meg, a comment rather than a question regarding clinician moral injury in the most extreme of circumstances. What I'm hearing here is a challenge for us as clinicians to shift many internal maps we have about our practice, including acknowledging that the context in where we are working is broken and redefining the goals around that showing up, that many of your examples showed humanity. So, thank you, Meg. Yeah.
Beautiful comment.
Yeah.
Thanks, Meg.
Yeah, absolutely.
And I think part of that is also not just being comfortable with not being able to do everything that you're trained to do, but also having some humility that you can't fix everything, and you'll never be able to fix everything. So what are the things you can focus on and do? Yeah, so lovely. Thanks.
Yeah.
Triumphs, gosh. A lot of my work in terms of implementation is very early days, I guess. Yeah, work to date has been much more around, talking to people, understanding suffering, understanding meanings of suffering, understand what might need to happen next.
Yeah.
But I think a triumph in increasing recognition for community-based efforts. When I first went to Gaza, there was very fledgling, very nascent palliative care starting to be thought about, talked about, kind of implemented, but it was very hospital-based, very specialist and very hospital-based kind of concepts, and that simply does not fit the context. It needed to be much more around home-based care, outreach, that kind of thing. So I think that's starting to shift. I think more and more community-based approaches, tapping into local community-based organisations, understanding, community networks that already exist is starting to gain some traction, which is wonderful. And the work that I'm doing in Syria at the moment, with some amazing local organisations and with HelpAge International, is around co-designing community services. So I think without using it as a buzzword and paying lip service to the concept of co-design, I think that's starting to be used as a way of thinking about how do we truly localise palliative care? How do we truly understand what's needed in these settings for these communities?
Thank you so much, Rachel. I could talk to you. I could just keep going forever, but I'm conscious it is 5 o'clock and I'm sure you've got many things to do this evening as well. Thank you to everyone who joined us today, and a big thank you to Rachel for your time, for sharing your expertise and your insights, and also just, I guess, the rawness of it and being really open to talk to the heart of what you're seeing in the work that you do. To everyone who's joined, we will send out the slides. It will be available. The recording will be available for those who weren't able to join this afternoon. And we've got an upcoming session. So the next one is a little bit different, a little bit of a different tone. It's so you want to be a NUM in palliative care. And we've got a few NUMs joining, one from, I think, Northern Territory and one locally here in Victoria. So that will be our next webinar Wednesday. So thank you very much, Rachel, and thank you to everyone for joining.
Thanks, Holly.
Good night.
Thanks, everyone.